My topic of presentation is lower extremity arterial occlusive diseases, epidemiology and natural history. So talking about the incidence and prevalences, first we'll go with the definition. Peripheral arterial disease is defined as a chronic atherosclerotic occlusive disease of the lower extremities. It is considered a major global health problem. This is due to the aging of the secondary to the aging of the world's population, and also with the associated risk factors like diabetes, smoking, hypertension, and dyslipidemia. The accurate information on the prevalences of PAD is very limited. This is because of the fact that affected individuals have a preclinical or atypical symptoms, and PAD screening is not a routinely used screening in the usual practice. So the extraction of the data is all by the isolated community screening studies done via questionnaire for intermittent claudication, or by extrapolating by other measured diseases like diabetes or events such like amputations. So epidemiological studies estimate that more than 200 million individuals are affected with PAD. The prevalence rate of PAD has increased by 25% over the preceding decade. The growth of this peripheral arterial disease evidently seen in both high income countries as well as low and middle income countries. Low and middle income countries and Pacific Rim, Southeast Asia region are demonstrating higher growth rates currently. And demographic wise, and age and sex related prevalence in high income countries, both men and women are equally affected, and the prevalence rate rises as the age increases. It is seen to be less than 5% in age less than 50 years, while it goes up to 20% in people more than 80 years. While in low middle income countries, women are seen to be affected more than men. Uh, the reasons behind this being women, they say they have a lower ABI compared to that of men, but nothing is proved as such. The data on the PAD is sparse for many areas around the globe. As per the US population, there's 8.5 million Americans who live with peripheral arterial disease. And Heller et al., who did a study by gathering the patients from the data he gathered, it was from the insurance, multiple insurances which provided to the patients, showed that annual incidence rate of PAD was 2.35%, and an overall prevalence was seen to be 10.69%. Estimates of prevalence of intermittent claudication and chronic limb ischemia are likely to be undervalued. The intermittent claudication is estimated to affect up to 6% individuals older than 65 years in the Western countries, while chronic limb ischemia incidence range from 0.02 to 0.35%, and the prevalence range from 1.2 to 2.35%. The increasing burden of peripheral arterial disease result in mortality, morbidity, and also escalating public health costs. The risk factors of the PAD is usually it's a chronic manifestation of systemic atherosclerosis in the lower extremities. Hence, it shares many risk factors with coronary artery diseases and cerebrovascular diseases as well. So it includes as demographics, age and sex, which as I said previously, in high income countries, both men and women are equally involved, while age it's seen more in the elderly age group. Smoking, as you can see here in the next slide, smoking, both in the past and current smoker, usually increases the odds ratio of having a PAD by 2 to 4 folds. And the associated diabetes mellitus also is a strong predictor of peripheral arterial disease. It is seen that both smoking and diabetes mellitus combined have uh, have a more severe PAD as a disease in the patients if they have both diabetes and smoking that is combined. And there are other risk factors are inflammation by seen as in by C-reactive proteins or D-dimer levels, which have some association, history of previous cardiovascular diseases, and dyslipidemia, which can be seen by increased total cholesterol levels, decreased HDL levels, and even cholesterol to HDL ratio also shows some impact, that is significance with PAD, sir. And yes, age, as the age increases, definitely the chances of peripheral arterial disease also increases by more than 20%. Anatomic distribution of the disease and the clinical need. So the diseases are described by three levels. It's divided into three levels, which are ioto-iliac, femoropopluteal, and tibiopedal. This is done because it is one, clinically useful, and second, there are associated. It is associated with patterns of risk factor as well. So, like for example, in patients who are smokers, there is high frequency of ioto-iliac and femoropoplar involvement, while those who are having diabetes are typically associated with uh, uh, tibiopedal or femoropoplar. It also shows relationship between disease pattern and clinical presentation. Like patients who are having intermediate claudication will either have a ioto-iliac or a femoropoplar disease that is involving a single segment, while one with who is having a chronic limb ischemia will have involvement of at least two arterial segments out of the three, or will have a severe tibial disease. Cohort studies, including vascular imaging, provide a greater insights into the anatomical distribution of these lesions. Dime et al. Has examined angiograms of about 2,659 patients who underwent endovascular interventions for PAD, and the study shows that proximal AI diseases were found to be in younger age group and male smokers, while the distal tibiopedal diseases was found to be in diabetes and advanced age. A similar study was done by Ruda et al., which shows that more than half of CLI patients had occlusion in popliteal and tibiopedal segment, and another 30% had combined femoropoplar and tibiopedal segment occlusion. While in the latter study, the patterns were particularly in end-stage renal diseases or diabetic patients. Grades of CLI. So uh, the classification is for a CLI is both Fontaine and Rutherford classification, where there are six grades as in Rutherford classification. Starts from asymptomatic to mild, moderate, and severe claudication. Severe claudication is defined as he cannot complete the standard treadmill test, and which is walking for 5 minutes at the pace of 2 miles per hour with an inclination of 12%. And that's grade 4 is ischemic rest pain, and 5 is a minor tissue loss, 6 is a major tissue loss. In clinical presentation, so uh, these patients present with asymptomatic disease, intermittent claudication, atypical leg symptom, and chronic limb ischemia, which asymptomatic disease being the majority of the patients being in this group. The reasons for lack of symptoms can be due to lower disease burden, or as the limb may have an adequate collateral artery reserve, or the patient being an elderly will have limited activity levels, because of which the symptoms will not be seen. Despite the lack of intermittent claudication, this group carries a high risk for significant cardiovascular events, a mortality, and a functional decline. Crick et al. Showed that in a study in patients who were having asymptomatic disease, although they were asymptomatic, they had a 2.7-fold greater risk of mortality and a 5.6-fold greater risk for a coronary artery disease related deaths. Notably, mortality and cardiovascular risk are strongly associated with both reduced ABI and also ABI more than 1.4, which is non-compressible ABIs. The risk of progression from asymptomatic to intermittent claudication is unclear, but meta-analysis estimates that there is a 7% risk of asymptomatic patients to deteriorate to intermittent claudication over a period of 5 years. So coming to the next group, intermittent claudication, it is a clinical syndrome characterized by reproducible leg pain brought on by exercise and relieved by rest. The other differential diagnoses that can be considered here are neurogenic pain, venous, musculoskeletal disorders like symptomatic Baker's cyst, and joint pains like arthritis. For intermittent claudication, there have been questionnaires which are formed like Rose questionnaire, San Diego questionnaires, by which one can assess if they're having intermittent claudication. But in clinical practice, a careful history with physical examination with a non-invasive studies readily establishes the diagnosis. So this is one of a questionnaire which is Edinburgh Claudication Questionnaire. It's an improvised version of the WHO bar Rose questionnaire where the questions are asked, and depending on the response, if a positive classification for peripheral vascular diseases requires the indicated response for the questions. So intermittent claudication may affect proximally, that is buttock, hips, or thighs, or distally in the calf. Calf pain is by far the most common presentation. So the symptom also reflects the arterial disease proximal to that level. And the severity of the intermittent claudication is described in terms of initial claudication distance. Generally, patients with severe IC, as I told, are unable to complete a standard 5-minute treadmill test. And there is a functional decline over time in intermittent claudication and is significant and is associated with severity of peripheral arterial disease. There have been numerous studies which have associated intermittent claudication with long-term cardiovascular events and mortality. Over 5 years, approximately 20% of patients with intermittent claudication develop a major cardiovascular event, and the mortality ranges from 10 to 15% over these 5 years. A symptomatic PAD is alone as a strong associated with CV events, more strongly than isolated CAD and coronary cerebrovascular diseases. 21% of the patients who experience it have a deterioration of the limb status over a period of 5 years. And the symptomatic deterioration is seen to be highest in the first year of diagnosis. Although the risk of amputation is less in this group of patients, this is less than 1% per year, its progression to CLI is associated with similar underlying risk factors, and patients who are having both diabetes and smoking appear to be of heightened significance. Then coming to the last group, which is limb-threatening ischemia, it is defined clinically as an advanced stage of PAD in which pain at rest in the foot or tissue necrosis has occurred. This term connotes the severe impairment of limb perfusion, which is insufficient to maintain baseline tissue requirements. The more recent consensus suggests the term chronic limb threatening ischemia as an alternative terminology. The hemodynamic criteria associated with CLA definitions are different with rest pain and for tissue loss, and also vary by the techniques that they are used. The techniques usually used are measuring the ankle pressure, the toe pressure, the tissue oximetry, or ankle or toe brachial index. The typical values for CLI are with rest pain, the ankle pressure being less than 40 to 50 mmHg and the toe pressure being less than 30 mmHg. While with tissue loss, the pressures are the cutoff values are elevated where ankle pressures are less than 50 to 70 mmHg and toe pressures are 40 to 50 mmHg. CLI occurs in about 1 to 10% of patients who are having peripheral arterial disease. A recent meta-analysis estimates the prevalence of CLI to be at 0.8%. Risk factors are similar to PAD, and diabetes and renal diseases have higher preponderance for the same. Most patients do not have an antecedent history of a classic intermittent claudication. This can be due to anatomic distribution of the disease, more so in having an infrapopliteal involvement or having a coexistent peripheral neuropathy, reduced mobility due to comorbid factors, and having an acute event such as trauma or infection because of which they come to a notice. Adverse systemic and limb prognosis in CLI who have not received an intervention shows that an estimated mortality rate at 1 year was 22%, while that of a major amputation rate at 1 year was 22%. So, although this was done in those patients who are not underwent, usually the patients who come to the OPD do undergo this intervention, and thus their statistics are not yet have are very rare. There's still statistics to be done for the same. Prediction models. So usually the prediction models keep the endpoints as mortality or major amputation. The reason with high cardiovascular risk and its importance for clinical decision making in CLI. This is why there is a requirement of prediction models which can help in this. So the usual predictors are advanced age, which is more than 75 years, renal failure, coronary artery disease, congestive heart failure, tissue loss, dementia, diabetes, BMI, or functional status of the limb. Frailty is recently identified as a functional measure. These tools have been developed retrospectively using data from cohorts who have undergone revascularization. None have been prospectively tested across full spectrum of CLI or CLT though. So these are a risk of prediction models, uh, which I use their endpoints as like mortality, perioperative mortality, and amputation-free survival, 2 year survival rate, and so on. Wi-Fi classification, which involves wound, ischemia, and foot infection. So this staging system applies to all the patients who are having rest pain or tissue loss, and it is combined with an objective evidence of peripheral artery disease. So it has three factors, which is wound, ischemia, and foot infection, and they are graded on 4 scale levels. Hence, there is a 64 combinations which are there, and it's assigned to 4 stages of clinical severity. This staging is expected to correlate with the amputation risk at 1 year, and multiple studies show show Wi-Fi staging is strongly associated with amputation and wound healing outcomes. It also predicts wound healing time and has been correlated with cost of care. So, as I said, there are 4 scores, starts from 0 to 3 in each wound, ischemia, and foot infection, and every patient based on the presentation are classified into these three. After which the SVS Wi-Fi clinical stage, where we can see the points that are formed uh, for each and every individual, where they can be categorized into clinical stage 1 to 4, where the risk of amputation is very low, which is 0.75%, and the amputation is considered to be major amputation, which is below knee or above knee. So risk is very low. But stage 2 is low risk with 5.9%. Stage 3 is 8.4%, and stage 4 is high risk with 25%. Clinical stage 5 is considered to be an unsalvageable limb. Screening for PAD. The role of screening in PAD is controversial, where even though it is seen to be that it is having a correlation with the cardiovascular events or cerebrovascular diseases, the statistics doesn't show the same. Well, US Preventive Services Task Force found that evidence to support PAD screening as insufficient in terms of balance and benefits and harms. And even the current SVS guidelines recommend against population screening for PAD, although they suggest that screening for high risk individuals, that is, who are having diabetes or who are elderly more than 70 years, can be done. The 2016 American Heart Association guidelines also recommend targeted ABI testing in asymptomatic individuals who are at increased risk of peripheral arterial disease. And these are the ones who are more than 65 years, the ones who are above 50, less than 64 years with atherosclerosis risk factors or having a family history of PAD, or the ones with more than 50 years with diabetes with an additional risk factor, or the individuals with established atherosclerosis in another vascular bed like heart or in the brain, CVA or CVD. Surveillance. So the benefit of surveillance with asymptomatic PAD is unclear. While patients with diabetes or CLTI should have regular foot examination, symptomatic patients with objectively determined PAD are typically followed long term, and symptomatic patients are followed up just to know that are they compliant with the lifestyle changes, are they okay with the medicines or the medical management that they are taking, and if there is an improvement or deterioration that is there. So current SPS guidelines suggest all patients with intermittent claudications to be assessed annually for the same, and patients with intermittent claudication or CLI who underwent revascularization should be monitored closely. The role of duplex ultrasound surveillance for a vein bypass graft, uh, although supported by many guidelines because it can help in promoting long-term patency, uh, it lacks level 1 evidence for the same. Post revascularization, semi-annual or annual follow-up should be done, and the patient should be assessed for lower extremity functional performance, new or recurrent symptoms, and they should have a complete foot examination. Thank you.